Good afternoon. Welcome back to our UCSF Department of Medicine Grand Rounds, COVID themed. I'm Bob Wachter. I'm chair of the department. The ground rules are up there. Feel free to type questions in the Q&A box. We'll take a look at them. I'm not sure there will be a ton of time for audience questions, but we will take a look if you have any. The session is going to be recorded and, as usual, be posted on YouTube tonight about 7:30 or so. We are using the automated closed captioning, so if it mangles some big words, that's just the system. But university is now making that available for many presentations, so I think that's great. And put your Zoom window in full screen mode. So today I think it's going to be a very interesting session. We'll start with an update on the state of the pandemic by George Rutherford, who at this point needs no introduction, but I'll briefly introduce him. George is professor in our Department of Epidemiology and Biostatistics. He's the medical director of our Prevention and Public Health Group, and for the past 15 months has been an indispensable educator of all of us on issues around the disease trajectory and COVID's epidemiology. And looks like in the US, news is pretty good, and the rest of the world, maybe not so much. So George will update us on that for the first 20 minutes or so. After George's presentation, we'll spend the rest of our time talking about an issue that comes up a lot, particularly at a place like UCSF, which is the impact of COVID on immunosuppressed patients. And the particular focus now, of course, is on vaccination and immunity. And our speakers will be Leanne Gensler, Shugan Aurora, and Brian Schwartz. I'll introduce them more fully when the time comes. And it's a pretty rich topic. We'll talk about a number of different cases. And so we may go a little bit past 1 o'clock. So if you're are able to stay with us for that, that would be great. I'm guessing about 1:05, maybe 1:10. Okay, with that, let me hand it over to George to hear about the state of the pandemic. George.
Thanks very much, Bob. So I was going to start off with the world and then work down and come back around to a couple of issues. Worldwide, as you can see, things are not going well. There are more cases per week now than there have ever been. Maybe it's leveled out here a tiny bit in the last 2 weeks. And mortality is climbing as well, almost up to where it was in the big winter surge here in the Northern Hemisphere. There have been 150 plus million cases overall and more than 3 million deaths. If you look by country, India, which is purple here, this is the South and Southeast Asia region of WHO. India is leading the surge, and I'll say a little bit more about that. But don't forget about South America. I'll show you that in a second. The European and the US outbreaks seem to be tapering off just a little bit. If you look across the world, India has the greatest number of cases in the last week, 6 times more than there were in Brazil, and 8 times more than there were in the United States. Then Turkey and France are after that. The next one after that is, by the way, Argentina. If you look here across the map, you can see this whole swath of infection that goes from India all the way up through Iran, who has a lot of cases, in Turkey, into Europe. England and Portugal are kind of on the other side of the epidemic now and are doing pretty well. In the Americas, this whole southern cone of South America, plus Brazil, Peru, and Colombia have all had major outbreaks. And with the, the population base in Brazil, this continues to be a major source of cases around the world. And then in the US and Canada, we're doing better. If you look, this is from our World in Data, a great site. If you can select out countries here, and these are the ones I selected. This is Brazil here, right? The US has started to fall, has fallen a lot. The United Kingdom has fallen tremendously. And this is with a single dose of AstraZeneca vaccine given to almost all the entire population. Here is India going straight up here towards the end, and then Mexico is also maintaining relatively low levels of infection right now. If we look at India, this is what their epi curve looks like with more than 21 million cases. and running at 400, more than 400,000 cases yesterday. They've had 230,000 deaths and almost 4,000 yesterday. India has in dire straits. They've run out of oxygen. They've taken all the industrial oxygen and moved it for healthcare. There are variants in India. There is the UK variant, the B117 variant, and also the B167, the so-called dual mutant, which actually has 13 mutations in it. There's the homegrown Indian mutation, which has this E484Q mutation, as well as the L452R, which is what's seen in the California or West Coast variants. The Indian variant, the so-called dual mutation, is what's predominating in Maharashtra, but you can see that they're also a major source of infection in other parts of the subcontinent. The 617 variant is controllable by current vaccines, but only 5.5% of Indian vaccines have been Indian adults have been fully vaccinated, and as a consequence, and not one that I don't think any of us would necessarily have not made had we been the Minister of Health of India. India shut down exportation of vaccines to try and get their population vaccinated as quickly as possible, which has thrown a huge wrench into vaccination programs in other parts of the world, predominantly in Africa. The vaccine supplies, given that they're very low levels in India, and the US has 300 million doses of AstraZeneca vaccine on order. We've already provided 4 million doses to Canada and Mexico, and the administration announced last week that we'd provide up to 60 million doses to India after there's a safety determination by FDA. Yesterday, the US Trade Representative announced that the US would support compulsory licensing of COVID vaccines. This is basically a waiver of intellectual property for public health emergencies. This is what Brazil did to start making antiviral drugs way back when. The World Trade Organization allows this under the trade-related international intellectual property, I can't remember what S stands for, settlement maybe. But this is part of the kind of the worldwide trade and intellectual property architecture. And countries who apply for a waiver can manufacture their own vaccines or biologicals without intellectual property infringement. And so if you have a big, robust vaccine industry, India, Brazil, Thailand, you can start to make your own vaccines. Here in the US, things are going well. And in California, they're going very well. The US still has 46,000 cases a day yesterday. And in California, we're down below 2,000 cases a day, which is a 21% change over the last 14 days. And we're down to 71 deaths. For 2 days last week, Los Angeles reported 0 deaths, which is a really quite an accomplishment given where they were. California, in fact, has the fewest number of cases in the country on a per capita basis. And we're ahead of Oklahoma and Mississippi, fear not. And we're way down. But you can see there are a lot of other places around us, notably Oregon and Washington, Colorado, that have fairly high case rates. Nationwide, the highest case rates the greatest number of cases are in Florida, Michigan, New York, Pennsylvania, Texas, and Illinois. But you can see all of these are falling. Colorado, not very much, but all the others are falling in double digits. Here in California, this is the current map. Both San Francisco and Los Angeles, interestingly, have made it to the yellow tier, along with Mendocino and Trinity and Lassen and Sierra. And Alpine counties, you can see there's quite a bit of residual transmission going on here in the upper Sacramento Valley from Madera all the way up to Yuba County, and then up here in the upper Sacramento Valley in Tehama and Shasta counties. So there is continued transmission through this agricultural belt, and including Solano County here at the edge of the bay. But the overall R sub E is 0.89. We have 1.3%, or 1.2%, I'm sorry, case positivity, and hospitalizations are down 12% from 2 weeks ago, and the ICU capacity is at almost 33%. And as I think everyone knows, on June 15th, the governor has said that given equitable vaccine availability for people 16 and over and a consistently low burden of disease, that we're going to get rid of the tier system and all sectors can return to normal with certain extra controls around large crowd events. We are seeing the number of people who are hesitant to get vaccines, saying they definitely won't. That's remained fairly stable. But it's also, quite we're seeing here, whatever this is, 79% of people saying that they would, are basically in the camp of getting vaccinated, 62% as soon as they can, and another 17 eventually. And this is pretty good. This is more than it was earlier on in December. So we're doing studies now in some of our big cohorts where we think that 97% of people who said they were in this category have subsequently gotten vaccinated. Here in California, we're currently vaccinating everyone 16 years of age and older. And then upcoming, probably early next week, when the FDA probably will extend the EUA for the Pfizer vaccine down to 12 years of age, we'll see this, that I would suspect what we'll see is that vaccination will open up to all Californians 12 years old and older. We've had administered more than 30 million doses, 225,000 per day the last 7 days, which is quite a bit lower than it had been. And here you can see how its vaccinations have dropped off, both in California, both nationally, as well as in California. And J&J vaccine is really down to a trickle. 48.2% of Californians have received one dose or more, and 33% have been fully vaccinated. San Francisco's quite a bit ahead, with 64% having received one or more doses and 44.6% fully vaccinated. Here in our two major clinical sites in the Bay Area, in Alameda and in San Francisco, you can see that we have quite high rates of, in the counties where those facilities lie, quite high rates of vaccination. And I didn't look up Fresno, I'm sorry. Now, one of the things that's emerged is this whole risk. It's a lot of discussion around variants. And I think we are all aware that the whole issue of how well vaccines work against variants, which will be discussed more today, has a lot more to do with, is more than just whether they're antibody produced or even neutralizing antibody produced. T cells have a tremendous role to play in vaccine associated immunity, and that's not anything we're measuring particularly in any particular depth right now. What we know is that based on the transmission rates, okay, this is looking at daily cases in a theoretical population. The more transmission there is, the more variants will arise. So this is the probability of an escape variant. So our task is to keep new cases low. And as I said, California is running roughly at a little less than 2,000 cases a day. This is 1,000 and this is 5,000. So if we can maintain that pace or even get it down farther, I think that would be even better. Let's see. Okay. Speaking of variants, these are the new CDC dashboard for variants. You can see how the B.1.1.7 variant has become dominant in the United States. The B.1.4.2.9 and 1.4.2.7 variants, the so-called West Coast variants, are being squashed down. These are the old variants that were circulating, as far back as January. So the B.1.1.7 has come on really strong and displaced a lot of other circulating types of viruses. In California, this is overall among all the things that have been sequenced and reported to CDC. 30% have been B117, and 38% have been 1427 and 1429. In Arizona, which has a relatively lower rate of disease, much like California, 32% 117 and 28% 427 and 429. However, if we look more recently or look by time, this is what the curve looks like with the California West Coast variants, 427 and 429 going up, peaking as a proportion in February and then starting to fall, whereas the B117 ones are coming up and have in April went ahead of the 1427, 1429 variants, with not an insubstantial amount of the Brazilian variant, the P2 variant. And then finally, just to mention that CDC has put out new data yesterday, doing their models of what's going to happen. So these are cases and these are hospitalizations, and there are 4 scenarios. This is the United States. 4 scenarios: low vaccination rates, low non-pharmaceutical interventions, meaning mask adherence largely, low vaccination, moderate NPI, high vaccination, low NPI, and high vaccination, moderate NPI. And this is looking at when we would expect cases to go to 0. In this higher scenario, in this sort of low vaccination, low NPI, you can see there's still cases out here past September, whereas in the these 2 blue ones, the high vaccination scenarios, you would expect to see some sort of getting down towards almost 0 by September 1st. And similarly for hospitalizations, although the hospitalizations actually go down a little bit earlier, which probably suggests this transmission is among younger people. So I will stop there and happy to answer questions.
Thank you, George. Terrific as usual. A few questions came in. I'll have a few of my own. Let's just start with the end game for a place like the Bay Area, where vaccination rates are 30 to 50% above California, above the US. Do we reach regional herd immunity? And what does that mean in places without walls and airports?
Or oceans around them?
Yeah.
I think we do. I think we do. Now, it depends on what you define as the Bay Area. Do we go all the way to Monterey and all the way to Mendocino? How far east do we go? But looking at least at the 9 county, maybe 10 counties with Santa Cruz, I think we do reach something that looks like herd immunity at some point in time, probably in the next couple of months. We'll see several other counties go into yellow over the next few weeks. Which means that we have very low levels of transmission, low test positivity, high testing rates because we're looking for disease, and low hospitalization. So I think, what we know is that we're pretty much there, and it's just a matter of staying the course and not making mistakes. And I have a list of mistakes you can make that I've shown in Grand Rounds before. But yeah, I think that works.
Yeah. What does that mean in terms of, okay, so it's September, cases are near 0, vaccination, 80% of people are vaccinated, but SFO is open and people are coming in from other cities, they're coming in from other countries. So what does that actually mean in day-to-day life in a place that has that kind of a vaccination rate?
It means there'll be an occasional transmission, but it may be propagated by, 1 or 2, 1 generation or 2. But it'll die out. It'll look much like measles does now. Mm-hmm. And we can have a little bit of transmission, but not a lot of transmission. Measles is much more transmissible, 5 times more transmissible than even the worst variants. So I think that's kind of what we're looking at.
Great. Nice for us. Kerry Kumar asked the question, if you had a 12-year-old, would you vaccinate him or her after the approval comes in next week?
Yes. Absolutely.
No
I'm a
doubt.
pediatrician. I'm a pediatrician too.
I understand.
Yeah.
So you didn't hesitate in answering that. So it's still relatively new technology, really low rates that a 12-year-old is going to get super sick. So why is the answer yes so clearly?
Because there are outbreaks in middle schools and high schools all the time. And in fact, that seemed to have led the resurgences both in Michigan and Minnesota and Colorado, and they all stem from youth sports.
Mm-hmm. And is your answer true when a month or two from now they come out and say we're good to go with 2-year-olds?
That it's not going to be. It's going to be more like 6 months, but I
Okay.
think it's, I don't know. I don't know. I'm going to have to. I think our thinking will evolve a little bit on that. The kids under 10 really aren't part of the transmission chains very much. Now they may be with the 117 variant. The British think so, but when they define child, they're saying under 24 years. So it's a little hard to tell. It's a little hard to sort that out. I think we're going to have to get a little bit more experience before we would make that push.
And is it because in a place like the Bay Area, there's so little virus that we
Right.
think will be around that the risk benefit may not be positive?
It may not, yeah, but
Yeah.
I think we'll have to see.
Okay. As I argued for the single dose delayed second dose early, does the UK experience prove that I was right?
It proves that they were lucky.
Go on.
I guess enough said. No, I think I think in retrospect, with AstraZeneca vaccine, which we do not have available, I think I think that shows that it can be done.
Okay.
I'm not giving you all this one, Bob.
No, okay, that's fine. Esteban Burchard asks, why is Africa so low? And are they still at, will they be the next India?
I don't know. I don't know. First of all, you have to realize that how young the African population is. There's this whole giant youth bulge in Africa in the demography. I also think that temperate climates, people are outside a lot more. There's much less indoor congregation. There's also wild under testing. And I don't think we really have a great handle on what's going on, except perhaps in South Africa, Namibia, Botswana, where there are, there's about 40,000 cases in South Africa. And the one thing in South Africa is that the B.1.351 variant is dominant now. It's 90% of the isolates. And the AstraZeneca vaccine doesn't work against that.
Mm-hmm.
And so they've had to really flip their vaccine strategy and try and import different vaccines. If that gets farther afield in Africa, it seems to be fairly concentrated in the southern part of Africa. That could rearrange things quite a bit.
In terms of sort of the things that might still keep us up at night in the United States, and particularly in a place like the Bay Area, it now seems like it's essentially all vaccine resistant variants. So is the growth of the P1 here a cause for concern, or is it proving that the vaccines work okay?
I think it proves the vaccines work okay. Again, this is a wait and see kind of thing. Part of it is that there's a lot of other vaccines that are being used in South America. A lot of the Chinese vaccines, like whole cell killed formalin inactivated, no, not formalin inactivated, but they're basically whole viruses that have been inactivated as a vaccine. It's real 50s technology, and they're not that immunogenic. So it's a little hard to piece together what exactly our risk is.
But from what we have seen over the last couple of months, if in January, so we were really worried about the South African variant and the Brazilian variant and what might happen if they hit our shores. They're now here. Is the news good in that they don't seem to have a competitive advantage for spread, or the news is good because the vaccines work, or both?
All of the above.
All the above. So you're less worried about those than you would have been 3 or 4 months ago. Is that fair?
Yes, that's fair. And understand the importance of T cell immunity that we're not measuring with all these tests. So.
Okay. Speaking of T cell immunity, why don't we move on to to our next segment? So George, thank you so much.
I was just trying to give you a little segue there. Okay.
Perfect. It's like we planned this. So let us move on to our next segment, and we're going to talk about issues in immunocompromised patients. And first of all, to say that this session was stimulated, as many of the sessions are, by a suggestion from one of our faculty members who you'll meet, Shagun Arora, that we had not covered this, and it's a hot issue. And I'd say a particularly hot issue in a place like UCSF, where we care for a lot of patients who are immunocompromised, either by virtue of their disease or by virtue of the medications that we give them for their disease. So this is a huge issue. And early on, it was a huge issue because we wondered and worried about their risk of getting COVID and their risk of progression and sickness. And now it's probably a bigger and more complex issue because of the role of vaccination. So that's what we're going to talk about for the next 40 minutes or so. And we have 3 wonderful speakers to help us wade through this. The first is Leanne Gensler. Leanne is professor of medicine in our division of rheumatology. She's director of the UCSF Ankylosing Spondylitis Clinic. And her primary research is in disease progression for spondyloarthritis. She also looks at predictors of osteoporosis development in patients with lupus. So Leanne will go first and give us kind of a foundational talk on some of the issues around immunology that are relevant here. Second speaker will be Brian Schwartz. Brian is professor of medicine in the Division of Infectious Disease at UCSF Health. He's got a lot of titles: vice chair for clinical affairs in that division, course director for the Pathogens and Host Defense Block in the School of Medicine, program director for the Infectious Disease Fellowship. Brian, I'm getting exhausted. And he chairs the Medical Education Community of Practice for the Infectious Disease Societies of America. His clinical work and research is on the diagnosis, treatment, and prevention of infections, largely in immunocompromised patients. So perfect to have you here, Brian. And third, as I said, suggested this topic and is here to present some of the cases that she is seeing. And this is Shugan Aurora, who's assistant professor in the Division of Hematology and Oncology at UCSF Health. She's medical director of the Infusion Center at our Parnassus campus. Her specialty is in caring for patients with malignant and non-malignant blood disorders with a focus on monoclonal gammopathies, which are conditions in which the blood contains abnormal proteins. So as I said, we'll start off with a couple of short kind of foundational talks so that we're all, as they say, level set. And then we will review 4 or 5 cases that bring up some of the key issues that I think many of us grapple with all the time. So let me hand it over to Leanne, who's going to start out with the first talk.
Thanks, Bob, for inviting me to be here today for this important conversation. And I am going to talk a little bit about just a primer on the immune system and then some results that we've generated. Next slide. These are my disclosures. Next slide. All right, so to start, I thought it important for us to just think about what is it important about the immune system as we think about vaccine and vaccine response, particularly in patients that have altered immune systems, either from their disease or from the medications we use to treat it. So you can think about the immune system as having 2 major branches: the innate immune system on the left. And this is really important in that it works very quickly, but it's not very specific. And it really actually helps the adaptive immune system to become activated. So you can think about that initial inoculation with vaccine as being important for the innate immune system. Compared to that, the adaptive immune system takes longer to work, but it's much smarter and it's more specific. And so it really is able to make this very intelligent and specific response, and it allows us to create a long-lived response to the exposures we see, whether it be infections or vaccines. Next slide. And so who are the key stakeholders or key cells that are important in this adaptive immune response? So at the top, you can see the B lymphocytes, and we'll talk about those as being B cells. And these B cells are really important in recognizing the foreign material, whether it be vaccine or infection, and then expanding or proliferating, and then becoming more mature cells, in other words, differentiating into what we call plasmablasts and plasma cells, and also memory B cells. The T cells are also important in antigen recognition, and they expand. And when they differentiate, they can differentiate into other kinds of T cells, and in particular, cells that help the B cells make antibodies. Next slide. So this shows nicely the temporal relationship from vaccination on the left with an mRNA vaccination, and then what happens over time. And so you can see the initial inoculation results in an innate immune response where lots of cells come to where the inoculation happens, and you might feel that as a sore arm. That then expresses the protein, and you can see the little spike protein that's being produced, which then is taken to the lymph node. And when it gets to the lymph node, it starts to meet up with B cells, and there's some T cell relationship too. And then the party really happens at the germinal center. So you can see the germinal center formation, and that is where the T cells and the B cells talk to each other, And from that, lots more T and B cells are made, but also differentiation happens. And eventually, plasma cells that make antibodies to the spike protein in this case leave the lymph node and go to the bone marrow, and they live there and continue to produce antibodies that then are circulated and help us prevent infection. Next slide. And so what are the goals of vaccination, in particular with COVID, but other viral vaccinations? And there's two. One is to prevent infection, and the other is to reduce the severity of infection if it happens. So we prevent infection really by the antibodies that we've made. Whereas when we get infected, we really depend on our T cells to kill the infected cells so that we don't have a severe infection. But you can see that it's really this relationship between the B cell and the T helper cell that allows us to make this robust B cell response. Next slide. And so emerging evidence suggests that the two are very connected, and that we already knew we needed a good humoral or B cell response for vaccines. But this is a preprint paper that suggests that actually a good T cell response correlates really well with a good B cell response. And what's important, I think, to this conversation today is that many of the medications we use suppress one or both of these arms of the immune system, and so may alter that response to vaccines. Next slide. And so this is just the last slide, and it's some of the work that we're doing to try to understand this relationship. And this is a prospective cohort of patients that have chronic inflammatory disease, both rheumatologic, but also IBD and multiple sclerosis. And it's a collaboration with Washington University. And so leading it at UCSF, I have to acknowledge Mary Nakamura is our lead investigator, but there's a lot of work from Radad Matlubian, Patty Katz, and then our fantastic fellow, Monica Yang, who's really sort of gone out and recruited patients with autoimmune diseases and inflammatory diseases on immunosuppressive medicines. And so we also importantly collected immunocompetent controls. And we were able to look at their spike antibody levels and quality of response, so neutralization of the spike protein, both before vaccination and then after the first boost at day 7. And so we did this because our medications we had concerns that these medications were going to have an effect on the immune response, both B and T cells. And so it is easier to study the B cell response as in the antibodies, but taking into account that very important also to address the T cell response. So there were things that we knew were going to be a problem. We use medications that deplete our B cells. Medications like rituximab, which are actually used outside of room. We stole it from hematology. We'll hear about it more today, but that is potentially a big problem if we're going to talk about making antibodies. There are drugs in the neurologic world that also deplete B cells, ocrelizumab. So we had concerns about these drugs. We had concerns about antimetabolites, medications like methotrexate that have been shown to have an effect on other viral vaccines like influenza. And so when we looked at these patients enrolled in the study, what we saw was that, as expected, B cell depleting drugs had an enormous effect on being able to make antibodies. But what was a little bit surprising to us is that medications like prednisone, which many of us use, had an impressive effect as well, and that there wasn't a dose-related effect. Other medications also had an effect, but to a lesser degree. So that's what I have to present today, and then I think we're going to talk lots more as we present these cases.
Perfect. Thank you, Leanne. So, and we'll get into, I think people could look at those numbers and say how much of a decrease is clinically important, and that, of course, will be something that we talk a lot about. Good. All right, let's bring on Brian to take it from there. There he is.
Great. Thanks so much for having me today. I'm going to talk about COVID-19 vaccines and the immunosuppressed host. Next slide, please. As I was thinking about this topic, there were kind of 5 key things that I was hoping to share with you. One, we'll just spend a mere moment talking about what might be concerns about vaccines in general in immunosuppressed patients. I'll share with you what is known about SARS-CoV-2 vaccines protecting immunosuppressed patients to date. I get a lot of questions, like many of you, about whether we should be checking anti-spike antibodies post-vaccine in immunosuppressed patients. Are there strategies that we could be using to increase vaccine response in our immunosuppressed patients? And at the end, I'll share some recommendations for your consideration. Next slide, please. So when you think about vaccines in general and immunosuppressed patients, there's really two things that I tend to think about. One is what we're going to be focusing today is reduction in vaccine efficacy. But I wanted to just take a second to acknowledge that when you do have live attenuated viruses or bacteria in vaccines and you do give them to immunocompromised patients, you worry about developing vaccine-related disease. The vaccines that we're talking about here, even like the J&J vaccine, which is an adenovirus vector vaccine, is not replication competent, and it's not something we're worried about. So again, we're going to be focusing on vaccine efficacy only. Next slide, please. So as we think about immunosuppressed patients, we all know this is a very heterogeneous group. There's lots of different medications that affect, as Dr. Gensler said, different pathways of the immune system, and therefore you're going to expect to see different responses to vaccines. Again, as Dr. Gensler said, that really the easiest thing for us to measure is antibody response. So far, the studies that have been published have been looking at antibody response. And I'm going to share with you a little bit about what we've seen to date. I'm first going to talk about solid organ transplantation. We are one of the largest solid organ transplant centers in the US, so I think it's important to start there. There's been 3 studies that have looked at vaccine response after 2 doses of an mRNA vaccine, and they've seen between 38 to 59% antibody response in this group. Several of the studies have all highlighted that the use of mycophenolate mofetil or CellCept as part of the immunosuppressive regimen has been significant in having a decreased vaccine response. When groups have looked at patients with hematological malignancy, again, a big mixed group of different diseases, about half the patients after receiving 2 doses of vaccine have had a positive spike antibody. But there have definitely been differences amongst groups. So patients who had B-cell CLL, only 23% of them were able to make a successful antibody response. And this is the one place where I actually found a little bit of data on a non-mRNA vaccine. So there was a study looking at patients with multiple myeloma, and they did see a similar response, but they only looked after a single dose of AstraZeneca vaccine versus the Pfizer mRNA vaccine. When they looked at patients who had solid tumors, so things like breast cancer or GI cancers in general, not surprisingly, given that the immunosuppression is less consistent and intense, they saw a very high rate of antibody response, 95%, although the studies were quite small. I did want to point out, though, that there was only a 39% seroconversion rate after a single dose, highlighting that even in this population, that making sure that you get both of your doses on time are probably quite important. And the last thing that I want to highlight is the fantastic work that Dr. Gensler and her colleagues have done around patients with autoimmune disease, where in general they found this 3-fold decrease in titers. And with those who got B-cell depleting agents, there was a 36-fold decrease in steroids, 10-fold increase. Next slide, please. So now that we are actually going about vaccinating patients who are immunocompromised, well, are we seeing breakthroughs? What kind of disease are we seeing post-vaccination? We definitely have been seeing a trickling in of case reports, but just last week was the largest case series that I've seen in immunocompromised patients. This was out of a report out of Florida looking at a large transplant center, and they identified 7 solid organ transplant recipients who presented with clinical COVID-19 following vaccination. 5 out of 7 of these patients had received both doses of an mRNA vaccine, and it was between 6 and 44 days after their second dose. When you looked at those 5 patients who had these 2 doses, 4 out of 5 of them were sick enough that they required hospitalization. They were noted to have infiltrates on chest imaging. And for the 4 of them that they did check antibodies, they were all spike antibody negative. I want to highlight, though, that none of them were intubated. None of them required care in the ICU. So even though they were antibody negative, maybe that there was enough around, or again, that their T cell immunity was enough to prevent it to go on to develop very severe disease. Next slide, please. So this is a question, as I said, many of us get, are should we be checking antibodies after vaccines in our immunosuppressed patients? And I wanted to address this issue. The first thing that I think is important to recognize is that you need to, if this is something that you want to do and you're considering doing, you need to make sure that you're checking the right test. The default test at UCSF in APEX is an anti-nucleocapsid antibody, which is good at looking at post-infection, but it is actually not what we are using to identify in post-vaccination response. So you need to specifically ask for the anti-spike antibody. And I'll tell you on the next slide on how to order that if that is something that you feel like you and your patient decide you want to do. I think in general, if your patient has a negative antibody response, it is likely that they are less well protected than somebody who doesn't. But I think we're all hopeful that even those that don't seroconvert maybe will have less severe disease due to some B cell response and T cell response. And that patients who have a positive antibody response are probably much less likely, and it's probably quite reassuring. I think what we don't know is how well this response sticks. Are we going to see increased waning of titers much more quickly than we would see in non-immunocompromised patients? And so I think when you, as the provider and the patient, are together and you're thinking about whether you're going to order this test, I think you need to think about what are you going to do with a positive result? What are you going to do about a negative result? How is that going to change your behavior? And if you get a positive result, are we going to accept one positive and have a behavior change indefinitely? Should we be checking it again? So I think this is an area that we need to continue to learn more about and how to use, but it probably has a place. And I think a lot of patients may feel more comfortable engaging in certain activities. Next slide, please. So as I said, I promised I would tell you how to order this test. So if you are going to have your patient come into UCSF to have an anti-spike antibody drawn, as of today, you need to order a miscellaneous send-out test, and then you write SARS-CoV-2 anti-spike antibody. When I was talking with leadership in the clinical labs, they said this will be changing soon, but at least for today and the time being, this is the way you do it. If one of your patients that you place an order in Apex, but you're going to have them go to Quest or LabCorp, there's actually an order that you can say anti-spike IgG, and that order is actually directly available now if they're going to go to Quest or LabCorp. Next slide, please. So are there strategies that we might be able to use to enhance the immune response in these patients? Well, there probably are. I think none of this is well known in patients who are getting COVID vaccines. And this is an area of active study. Things that we can imagine we would be doing are increasing dose of the antigen. So one example of this, the way this works in a group of solid organ transplant recipients, when they got the high dose flu vaccine versus the normal dose flu vaccine, they saw increase in titers. So that may be an avenue that we will take in the future. Given that the immunosuppressive agents are the ones that are probably suppressing the response, you could imagine delaying the administration of immunosuppression, or if they're on it, doing a hold might be something to consider. This has been studied in patients with rheumatoid arthritis, where they've done holds of methotrexate in many different ways when they were getting their flu vaccine. And what they found was they did get an increased response by doing that, but there were also patients who had increase in flares. So you have to balance a hold of medication versus and the negative outcomes versus what the potential of getting a boost in response. And again, this is an important area for study. And the last that probably a lot of you intuitively have thought is like, should they be getting a booster? And would that help? And we see this in certain things like hepatitis B, there's some data. And I think this is another area where active study is happening. Next slide, please. So in conclusion, I'll share some very general recommendations for you for your consideration. I think the first thing that you want to think about and talk about with your immunocompromised patients who may or may not have a good response to a vaccine is that we all know that getting infected happens most commonly at home. So you want to have them build a wall of immunity at home, making sure that their family members, that their close friends are all getting vaccinated is going to significantly reduce the chance of them getting infected. Number two, if you have the possibility of vaccinating and completing that series before you start immune suppression, then do that. Then that makes a lot of sense whenever possible. Bryn Boslett and Sasha McKenzie at UCSF have put together a really nice document that is available on our website, UCSF Vaccination of Special Populations Guidelines, and they make recommendations for lots of different populations about how to coordinate the vaccination and the immune suppression, and I highly recommend checking that out. There are ongoing studies right now looking how to enhance the response in a lot of the different ways that we mentioned. I would say for the most part at this point in time, we're going to need to think about many of our vaccinated immunosuppressed patients as unvaccinated, particularly some of these populations that I mentioned, like our organ transplant recipients, our patients with hematological malignancy, maybe those who are getting B-cell suppressive therapy. And they're going to want to still think about masking and distancing when they're around unvaccinated persons. And that I think that the decision around getting an anti-spike antibody test is really going to be for each patient and provider to decide together. But I'm hopeful there'll be more studies and that we'll be able to have some really clear guidance on how to do that well. Thank you.
Great. Thank you, Brian. Thank you, Leanne. I think that was fantastic. And some of the questions that are embedded in the cases, I think you've probably already partly answered. So let's bring on everybody. Great. And I think, Shagun, you're going to present the first case. And I think Brian's covered a fair amount of this already, so we can go fairly quickly. And as I told folks in the beginning, it's now 12:47. We'll probably go till about 1:10 because I think there's a lot of stuff to cover. So why don't you start with the first case and we'll work our way through it.
Great. Thanks, Dr. Wachter. And thanks both so much for those terrific presentations on really important topics. So I'm going to start presenting a few patient cases that I think we've all encountered in our immunocompromised patients. So the first one and the first question will go to Dr. Gainsler. So we have a 65-year-old female who's been on long-term immunosuppression for her underlying disorder, and she's deciding whether or not to get vaccinated. So she hasn't been vaccinated yet. And I think a really important question is, what's her risk of contracting COVID and what's her risk of getting a severe disease state from COVID itself?
Thank you, Dr. Arora, for that question. And of course, I think we have patients with many different diseases and many different drugs they're on. So it's not a one answer for all patients. Answering the question about the risk of infection is actually quite difficult, at least based on the data we've collected. Janus Yazdani at UCSF has been leading a global rheumatology alliance looking at patients that get COVID and then their outcomes. But of course, the denominator there is COVID. And so trying to understand the risk of getting COVID is very difficult. And of course, our patients that are immunosuppressed have differential behaviors to be perhaps more protective about their risk of getting infected. So what we can do is extrapolate from other viral infections, and certainly clinical trials that have been done with immunosuppressive meds suggest that exposed patients have more risk of viral infections and nasopharyngitis and severe adverse infections such as pneumonias compared to the placebo group. But we can't answer the question with COVID directly. What we can say is that when a patient gets COVID who is immunosuppressed, there are certain medications they're on that probably increase the risk of them having a worse outcome. And those include, in particular, B-cell depleting drugs like rituximab, and then certain doses of glucocorticoids, so certainly prednisone at a higher dose. If you're on that for your disease, at 10 milligrams or more was associated with a higher risk of being hospitalized with COVID. So we sort of know that it's not just the disease or the drug, but depending on what the dose of the drug is, that really relates to the severity of the disease.
I think it's really helpful to encourage these patients to get vaccinated. I think, Brian, Dr. Schwartz, you answered a lot of questions about the safety of the vaccine in our immunocompromised patients, but how likely is it that the vaccine is going to provide protection to a patient who is immunocompromised on immunosuppression and or prevent a severe infection?
And I'll add to that, Brian. In the slide you showed the 50% range, it wasn't clear to me whether it was a 50% reduction in antibodies or it was a sort of a yes/no question, meaning that 50% did not have any detectable antibodies. So maybe if you clarify that as well.
Sure. So in the table that I shared, it was a 50% like response, antibody response. So half the patients had a positive antibody and the other half did not.
Got it. Okay.
Great.
Go ahead and tackle the question.
Yeah, I mean, I think it's an important question, and I shared with you pretty much everything that I know to date in terms of efficacy, as I mentioned, and the B cell response being low by antibody probably doesn't fully say whether that arm of the immune system isn't going to provide some protection. And talking to colleagues like Mike Peluso and Tim Henrik, it sounds like doing T cell assays are an incredible amount of work. And I think it's hard to know clinically what they mean, but I'm hopeful that arm of the immune system is at least preventing you from going on to developing severe disease. I'm hopeful that what I shared about the solid organ transplant patients, it was some vaccine response that helped. But I think, again, our ends are so small right now that we just don't have enough information, I think, to make really good judgments.
But would you, or I guess either any of you, anticipate that when someone has no antibody response, does that map to no T cell response as well, or are those things dissociated?
I can only share that what I've heard from, I think I was talking with Tim Henrik last week, and what he had said that in their lab was B cell response and T cell response has been correlating quite closely. So when they're high, they're both high. When they're both low, they're both low. That's all I know.
Yeah, I agree. And I showed that preprint, which showed this very strong correlation, but I think that we're easily able to measure this B cell response, and there's no commercial assay for a T cell response, and it is really difficult and expensive to do. And that the fact that you really require the relationship between the B and T cells to have the optimal response. So if one is down, it's likely that the other one is not working perfectly either.
Yeah, so Dr. Schwartz, if these patients decide to get their antibody checked and their spike antibody is negative, what are we going to tell them about what they can't do? How should they act? Do they act like a vaccinated patient or an unvaccinated? And, I think a really big question that I would love to hear how you respond to your patients about is, can they travel?
It's a great question. My take is, given the limited information that we have, if I had a patient who had a negative antibody, I would recommend that they act as though they are unvaccinated and mask and distance and behave in that way. I think in terms of travel, that's an individual decision based on what they want to do, what's important for them, and I think the risk often is related to the rates in that area. And I would recommend that they weigh the cost benefit analysis, and I'd help them do that.
Yeah. And I really liked the way that you described building a wall around you. So being around other vaccinated people helps protect you as the immunocompromised patient. I think that's good for that case. And maybe we can move on to the next case.
Dr. Walker. So Brian, we talk now in sort of it's negative or it's positive. Does the test come back with levels of antibodies, and are those levels useful in making a decision? So if I come back positive, and it's high positive, am I like a vaccinated person who's not immunocompromised? How do you interpret the positive result?
So where we've been sending ours at UCSF, we send it out to ARUP. And I believe that the cutoffs are, if it's greater than 1.2 or 1.1, it's positive. There's an indeterminate level, which we all love indeterminate levels. And then there's a negative. I don't think that we have gone through or at least not that I'm aware of what those ARUP values are and how they correlate to like neutralizing antibodies and how to tell somebody. I think, in my opinion, I'm going to say if it meets the positive, then I would kind of put you in the positive category, and anything less, you're not. But I think this is an area for learning.
But it sounds like you're telling a positive patient who's on significant immunosuppressives that you may not be the same as a positive patient who's not immunosuppressed in terms of the freedom that you feel to take the mask off and sort of go back to normal. Is that fair?
I think it's very fair.
Okay. Anybody want to add anything to that?
Yeah, no, I agree. I don't know how, there's no reference ranges on the semi-quantitative spike protein antibody. And then the other thing we, of course, recognizing it's only one part of the immune system, the other thing we don't know is how long it lasts, right? So if you come in at a lower level than some reference, which we don't know, is it going to wane faster? Will you lose your immunity more quickly? And what do we do with that?
Okay, Shagun, what are you on for the second case?
Yeah, okay, so I think a similar scenario, another 65-year-old patient who has had an indolent lymphoma for many years and suddenly becoming more symptomatic, like with their hematologist recommending treatment. But there could be some delay in treatment if we needed to do something else, such as get them vaccinated. The patient is not vaccinated yet. So Dr. Ginsler, do you think in the chemotherapy, the therapy we would like to use is a combination chemoimmunotherapy, including an anti-CD20 monoclonal antibody rituximab. So do you think that the monoclonal antibody treatment should be delayed until the immunization is complete? Why and for how long?
I'm so glad I'm not a hematologist. But I do think it is this balance between the disease that has the indication for treatment and how active that is and the risk of not treating it versus the risk of not having COVID immunity. And so in the setting of an indolent, and then I think it's very much a shared decision, right? At the end of the day, this is a discussion with the individual patient as to their preferences, as long as we've counseled them to the risk and benefit of treating or not treating. So with an indolent lymphoma, I think probably if you can wait and vaccinate first, then once you treat, it's just going to be so much harder to be able to gain that full immunity, even if you hold. And so what we've seen in our rituximab treated patients is that if you vaccinated within 6 to 9 months of a rituximab infusion, there was virtually no humoral B cell response. And once people started to repopulate their B cells, they started to have a response, but it was still not to the same level as people that were not immunosuppressed.
So, I mean, we're talking about not waiting a couple of weeks. We're talking about waiting nearly a year before reconstitution.
Potentially, depending on the individual patient, versus waiting how long it takes to build up plasma cells, right? We want those long-lived plasma cells that are going to go to your bone marrow and they're going to continue to secrete these antibodies to prevent infection. So, you know, we think that takes somewhere between perhaps 4 to 6 weeks to constitute that full long-lived response.
Yeah. Shagun, are you going to wait? Are you comfortable waiting that long with your patient?
Yeah, I think in someone with an indolent lymphoma who is not too symptomatic, then you can wait usually. And I think that this is an important thing, especially in the face of a pandemic. And so our practice, if we have the luxury of being able to wait, is getting the full vaccination series in and then waiting 4 weeks if we can before starting the CD20 monoclonal antibody.
Yeah, I might give a slightly different answer, tempered by what George showed us, which is, the risk of COVID is also partly dependent on the community prevalence. And if you're in San Francisco and we look at those CDC curves, the chances, these days we're seeing 15 new cases a day in the city of 900,000 people. So as you weigh that risk benefit, it can't just be in the face of a pandemic. It really has to be what is the ambient condition and how risky really is it in terms of COVID. And that risk has changed a lot. It's going to change further over the next few months. I don't know, Brian, do you have any comments about that?
I don't have anything to add.
Okay.
Brian, I actually have this interesting question. So if this patient had the luxury of choice, do you think an mRNA 2-shot vaccine or an adenovirus 1-shot vaccine would be preferred in a patient who's immunocompromised, such as which one would mount a more robust immune response? And of course, prior to any immunosuppression being given.
Yeah. I think we have a lot to learn in this area, but given that, I think we have suggestion that the mRNA vaccines probably generate a little bit more robust response. If you look at the data that was broken down from the J&J vaccine, patients over the age of 60 who had multiple comorbidities tend to be less efficacious. And so I would be a little bit more nervous in an older patient with a lot of comorbidities to give the J&J. That being said, if I would, if you only have certain options, I would certainly not tell them to get the J&J for sure. But if I was given a choice and they were both sitting there in front of me, I'd probably go for the mRNA vaccine.
Great. All right, why don't we move to, I think, Leanne, you had a case that you wanted to present?
Yeah, I mean, I think so. I saw a patient in late January, early February with a new diagnosis of polymyalgia rheumatica. This is a disease state that affects older patients, and the primary treatment is glucocorticoids or prednisone. And so, of course, at the time, we didn't have our study results back, and nobody thought that a dose of 15 milligrams of prednisone would significantly impair the vaccine response. And so I put him on prednisone, and then he got vaccinated per his age group. And of course, then we got our study results. And I have to say, one of the most difficult conversations I had with the patient is breaking this news of perhaps he hadn't had the response after a year of a pandemic that we had hoped based on the clinical trials. And so the question is then what to do with this patient that is immunosuppressed, that's been vaccinated, and should we be testing their antibodies, and then how do we interpret those results? And again, I think Brian brought up thinking about boosting them a second time. And so what to do with this, and then how to move forward. So
you're thinking about boosting a second time, you're talking about then stopping the prednisone for a while and then potentially giving another shot?
Well, that's a good question in terms of would holding, and that we don't even know, would holding the medicines that a patient is on make a difference for that boost? I think in the setting of polymyalgia rheumatica, that you taper the prednisone over time. So by the time you get to month 2, you're really down below 10 milligrams. Would that be important? Our study suggests in patients that were immunosuppressed, the dose didn't make a difference. But what we can't control for yet is the disease activity. People on prednisone typically have more active disease. And so perhaps there's something about the immune system that's driving that lesser response. And perhaps it's about how long you've been on immunosuppression that also affects vaccine response. So mostly what I came up with is questions, but I think prednisone is a drug that we all use, even in primary care. And so how to think about using it in patients that are getting vaccinated.
All right, Brian. So Leanne's asking for a consult.
I think at this point in time, I think I would not be recommending boosters to anyone outside of a trial. And I think this is, again, an important area to study. And I think that we should be looking at that in a systematic way. I think as the rheumatologist, playing around with, getting an antibody test, reducing the steroids, repeating one if you wanted, I think that all seems super reasonable, but I think it's hard to know, to be giving extra doses at this point, just so we don't really know that there's a lot of benefit outside of trial, probably would not be what I'd recommend.
Any idea, any sense that it would cause any risk to do, and also are we allowed to under an EUA to give something out of the EUA protocol?
As far as I know, I don't think that that's part of the recommended way we should be giving it. So I don't think so.
Any reason to think that it would be risky to give someone a third dose of Pfizer or Moderna?
Not that I can't think, except for having a more severe vaccine reaction. I don't think it would be dangerous.
That's what you're hoping for, actually.
Right.
In a way. Okay. Good. So Leanne, so what did you choose to do?
So I did check the commercially available semi-quantitative antibody, and it's positive. But again, I don't, it's one part of his immune response, and I don't know what it means compared to what an immunocompetent patient or person would, how they would respond. And then the other question is whether it would wane faster. And so I agree with Brian that this really actually needs to be studied, particularly in people that had no response, as opposed to a partial response. You would hope that you would get more bang for your buck. I think we know that if you look at people that have been infected and then get vaccinated, compared to people that were not infected and get vaccinated and then boosted, those people that are infected and get vaccinated don't have much more gain from that second vaccine compared to the people that really do need both vaccines to have that full response.
Okay. Shagun, why don't you go ahead? And I think there's a fourth case. And,
Great.
And the folks are still with us. We've lost a few, but not many, which is great. We'll go to about 110, 112 or so, I think.
Great. I think this is an interesting case too about exposures, right? We have so many patients who are living with family members. So an immunocompromised patient with multiple myeloma who's on long-term maintenance therapy, and his 33-year-old son lives with him, unvaccinated, developed symptomatic, COVID infection. Excuse me. So 2 days prior to the son getting developing symptoms, they all drove together down to Tahoe. So they were in a close proximity for the entire weekend. They live in a 2-bedroom house, so separate rooms in an apartment with 1 bathroom and 1 living room. So I think that the immunocompromised patient now has a high-risk exposure from the sun. So how can the immunocompromised patient protect himself against symptomatic SARS-CoV-2 infection? And is there some prophylactic treatment available to the immunocompromised patient? And lastly, should the patient's son get vaccinated?
And I missed, Sharon, whether the older, I'm about to say elderly, but he's younger than me, the older patient has been vaccinated or not?
I'm sorry, I missed it.
Has the patient with the myeloma been vaccinated or not?
He has been vaccinated.
Okay.
Thanks.
Which one of you wants to tackle that one? And maybe it's a Brian question.
I mean, I'm happy to address the idea of if you have a immunocompromised patient who's exposed, like what are some strategies to think about? I mean, I'm hoping that we're close to having an expanded EUA on this, but there's some really nice data with that came out with the Regeneron monoclonal antibody combination that showed subcutaneous injection of that in people who were exposed to a person with COVID actually reduced their hospitalization rate and getting clinically ill. So that would be great. Unfortunately, the EUA does not allow for like prophylaxis, post-exposure prophylaxis right now. You could potentially apply for a single-use IND, and I've heard of some people doing that in that setting. Alternatively, you could just wait, and if the patient develops any symptoms, at that point, you could then bring them in and get them a monoclonal antibody infusion, and that maybe end up being what you would do.
And Brian, just connect the dots. Why would the monoclonal work okay when vaccines don't?
The vaccine, we're asking your immune system that may be dysfunctional to make an immune response. Whereas when we're giving a monoclonal antibody, we're actually giving you the antibody that attacks the spike protein of the vaccine. So it's active versus a more passive immunity process.
Makes sense. Great. Okay. Any other questions, Shagun, you wanted an answer on that?
Oh, that was perfect. Thank you.
Great. Okay, so the last case, and this is a 55-year-old man, 2 years after a lung transplant, who's immunosuppressed on prednisone, mycophenolate, tacrolimus, admitted with fever, shortness of breath, and a chest CT showing ground glass opacities. 6 weeks ago, the patient was admitted and had COVID and was treated with remdesivir, convalescent plasma, and discharged home. Now has a PCR for SARS-CoV-2 that's positive. Again, I don't think we know for sure whether it ever was negative. We'll assume we don't know, with a low CT value of 12. So we're going to need some translation of the CT value. So I think maybe to Brian, is this a new infection or is this the old infection, and how would you sort that out?
So I agree with what you're saying. If we don't have a lot of values in between, it's hard to know. But I think it's important to recognize that many of these very immunocompromised patients, we've seen this in patients on B-cell depleting agents. We've seen it in solid organ transplant recipients, that they have actually a really hard time clearing the virus. And there have been some really interesting case reports where you'll see people who have infection, they will clinically improve in the setting, getting some treatment. They've even reported and showed their viral loads have gone down. And then a couple weeks later, come in with recrudescence of symptoms and increase in viral load or decrease in CT value on a PCR test. And so my best guess in a situation like this, given the host, that this is actually persistence of infection that maybe got knocked down with the remdesivir and convalescent plasma. And as those things have worn off, the virus has now come back.
So as opposed to, it's not sort of long COVID in that it's your immune response continuing to to cause you problems. It is the virus that never quite went away, was hanging out, hiding a little bit, and now has come back out as you've stopped the medications.
Absolutely. And there are, as I said, a bunch of case series and have looked at patients who remain culture positive many, many months following. And it's hard to figure out how to treat these patients. A lot of times we'll retreat them with remdesivir. We may give them convalescent plasma again. But one of the strategies too would be reduction in immune suppression and hoping their immune response can kind of get on board and get the viral infection under control.
Is this patient still contagious?
I would say that it is very likely that this patient is still contagious. And if you look at like recommendations for discontinuation of like quarantine and precautions, for most patients, it's just like it's a number. It's a number of days after onset of illness. Whereas in severely immunocompromised patients, it's the one situation where people actually consider repeating testing over time to actually document like not being contagious anymore.
And you mentioned, thanks, you mentioned might give convalescent plasma, which is a term I don't hear banded around very much anymore, as opposed to 6 or 8 months ago. So why that, and why not monoclonals in this patient?
Yeah, that's a great question. So the EUA for the monoclonal antibody is you can give it in the outpatient setting, or you can kind of fudge it a little bit and give it in the inpatient setting for somebody who's admitted for something other than COVID. But the studies that have looked at it in hospitalized patients have actually not shown that it's effective. However, that's in like normal patients. I think our feeling is in immunocompromised patients who are not mounting immune response, it likely has efficacy. But because we can't give monoclonal antibody, we use convalescent plasma as the alternative.
With, I assume, nobody believing that's the better choice.
I think for the most part, we would probably use monoclonal antibody if we had the ability to.
So this might be someone that you wheel down to the parking lot for, for the monoclonal. And what do we know about these patients in terms of their long-term outcomes? Do they just retain this positive infection for a long, long time? And what happens?
I mean, I think a lot of the patients have eventually cleared. I mean, it's interesting if you look at their clinical trajectory too. They're not always super sick. They're just kind of like waxing and waning clinically. But I mean, it seems like a lot of them usually will clear. But again, there's cases of people like 120 days post-primary infection that are still culture positive. It's rare, yeah, but it happens.
And do any of them just get put on long-term antivirals?
I have not seen that done. We've given patients more than one round of remdesivir, but I don't, outside remdesivir, we don't have any other antivirals that we know would work. And that has not been a strategy I've heard of.
Got it. Well, we need to quit. Any final comments from the three of you? I think this is really rich, interesting, complex session where we learned a ton of what we know. We learned a ton about what we don't know and some of the hard calls that you have to make in real life with big knowledge gaps. So thank you all for doing it. And any final comments or observations, Brian?
No, I mean, this is fascinating. I'm so excited to continue to learn over these coming months. And I think a month from now, this conversation will be different than it will be 6 months from now.
Yeah, Leanne?
Yeah, no, I agree. I think that this is the first time in this last year where we've really practiced without evidence in some sense, and being open to that evolving evidence is critical. And I think we've identified unmet needs today, both in our immunosuppressed hosts in terms of should we study treating them with monoclonal antibodies? Should we be boosting them? I think these are all really important questions. And can we study their T-cell response as that other part of their immune system to figure out actually whether that is intact?
Yeah. Shogun, any final observations?
I'm just so thankful that we have such an excellent ID department and immunology, allergy and immunology department, and people that we can talk to and bounce these ideas off of. Our patients really depend on us, lean on us for all of these questions. And so I think this conversation will continue. We're going to continue to learn a lot. There's so much study occurring in this specific field. So I look forward to being able to treat our patients better and get them through this.
Thank you. And thank you for the idea of doing this. And I'm struck by Leanne's comment. It really does feel like March or April 2020, except now with a very, very specific patient population. For the rest of it, I think we've sorted out so many of the answers, and it just shows the importance of getting real evidence so we can make better decisions. This is still a little bit of an information vacuum. So let us quit. Thank you all for joining us today. And we had about 600 or 700 people online. We'll post this tonight to YouTube at about 7:30. Thanks as always to our crack production team who are up there. We'll be back next week with a non-COVID themed Grand Rounds and back with another COVID session in 2 weeks. And then we'll think about how we do things over the summer. We may go down to once a month, depending on what's new and evolving. But as long as things continue to look pretty good, at least where we are, we may slow down the frequency. We'll see how things go. So thanks to everyone. Please stay safe. Please get vaccinated, and speak to you soon.